Brian, thank you so much for that amazing introduction. You guys should have very low expectations for the rest of the talk compared to what you just did. Guys, it's just an absolute pleasure to be back with you here today. This is really the first time I've been in this hospital in 14 years. I mean, it's changed so much. And I'm so excited to talk with you about a population of children with medical complexity that I care very, very deeply about. And that deep caring is directly because of you. I mean, you guys in residency challenged me, to try to do my best to engage in helping these children and to be the best general pediatrician I could to take care of them. And I've tried to do that and to make you proud since leaving residency. So the goal of this address is pretty simple. I just want to convey the current healthcare happenings and experiences of children living across the United States who are challenged to live with debilitating, complex chronic illnesses. We'll cover 4 topic areas here over the next 45 minutes or so. I'll cover their prevalence and impact on the U.S. healthcare system. We'll talk about different activities and approaches to managing their care, the relationship between the quality of care these children receive and containing their healthcare cost. And we'll wrap up with some state and federal healthcare policies that are enabling a better health system of care for them. Before we get started, just a few disclosures. I want to acknowledge all the funding sources that supported a lot of the work you're going to be hearing about today, especially from the Children's Hospital Association, who've been phenomenal with all of their data and analytic work. More importantly, all the people that contributed to the work that you're going to be hearing about, the clinicians, the researchers, quality improvement specialists, policymakers, administrators, parents who've guided and mentored me along the way, and especially the folks here who've continued to have a great relationship with me and mentoring me from afar, especially the Bryans, Brian Good and Brian Stone, Nancy Murphy, Chuck Norland, and especially my main mentor, Raj Srivastava. And most importantly, I couldn't get away without doing grand rounds without disclosing my top 3 favorite residency moments. Just give me 90 seconds on this. This is by far the best slide in the deck, and you're welcome to leave after this if you would like. As Brian alluded to, we started a band in residency called Failure to Thrive, and our lead singer was Tom Conover, if you know Tom. Tom disclosed to us once secretly that he had a crush on Susan Etheridge. After he told us this, the band got together and they wrote a musical parody called "Ablate My Heart" about Tom's love for Susan. All right? The chorus of this song goes like this. She's caused more flutter than she ever did cure. And she's got my juices pumping in a way that ain't so pure. Our love will never end because it failed to start. And if I'm doomed to never have her, then please, ablate my heart. Yes. Second favorite moment, this is for Joyce Soprano listening in from Disney World. Joyce once excused me from an ED shift because she told me that I smelled bad. I literally went home and showered, changed my scrubs, and came back. And I don't know if Jeff Shunk remembers this, but when I actually came back, he said, "Jay, you kind of smelled, but it really wasn't all that bad." The third story. So one Sunday, an Easter Sunday, Brian Good and I are rounding in the Well Baby Nursery, and Brian shows up to round in a bunny outfit. It is a head-to-toe bunny costume with the ears, the feet, everything. So he's rounding. He's going through the motions, in and out of the parents' rooms. Everybody's loving it. And then the nurse manager from the OB ward walks up and says, "Brian, I need you to take off the bunny suit." And Brian says, "Oh, I'm so sorry if I offended anybody. I'm really sorry." And she's like, "No, you don't get it. All the nurses keep staring at you and are imagining physical interactions with you in the bunny suit. They're so distracted that they can't continue on with their work." I'm sorry, man. I just had to tell that story. All right, enough shenanigans. So let's begin, all right? Over the next 10 minutes, I want to present to you information about the prevalence and impact of children with medical complexity on the healthcare system. Let's get into the weeds of this. A lot of data will be presented. Just bear with me, and I'll give it all to you. So I want to start things off with the clinical case. I want you to think about a 14-year-old with cerebral palsy who has the following clinical attributes: Shannon hydrocephalus, a neurogenic bladder, scoliosis, hip dysplasia, asthma, reflux, epilepsy, intermittent diabetes insipidus, and osteopenia, who also have some functional limitations, is assisted with gastrostomy, orthotics, cathing supplies, and an augmentative device for communication. also has some familial issues going on, parents who have ongoing financial and home caregiving struggles. So if you're a general pediatrician and you see this kiddo showing up on your patient panel and you've got 20 minutes to do a well child check, I think you might look at this kid and say, maybe this kid does meet the sniff test for medical complexity. All right? Now, beyond that, the health services team for this child is also very complex. This kid's got like 17 different providers involved in trying to help. Lots of specialists, lots of folks on the community side, and the parents are sort of stuck in the middle of all this, trying to manage all these people and figure out the roles and responsibilities and what they're doing. Even beyond that, the health services for this child is also pretty darn complex. This kid is on 8 different chronic medications at any given time, has had 10 surgeries, 15 acute care hospitalizations, has been to the ED 45 times throughout their life, 150 outpatient clinic visits, and over 600 telephone calls to the clinic. All right? The health record size of this kiddo right now is like 2.4 gigs. It takes like 37 minutes for this thing to load up in your health record. And right at the very end of it, when it's about to all kick in, like there's a power surge through the Salt Lake Valley, and the wildcat lifted altitude just kind of slows down for a minute. You know what I mean? So when I think about children with medical complexity on the population level, I think about kids with the following attributes. Children that have a lifelong, life-limiting chronic condition that's severe enough that it affects multiple organ systems of the body, and it's severe enough that it really affects their functioning, their ability to eat, to breathe, to digest food, to think, to walk, to talk. These children have myriad of healthcare needs to try to optimize their health, multiple medications, lots of durable medical equipment. And because they're in the health system all the time trying to get their healthcare needs met and they get sick so frequently, they're high resource users. Now you can think about all the chronic conditions that on the severe end of the spectrum are going to fit the bill for those attributes. Kids with cerebral palsy, spastic quadriplegia, complex congenital heart disease, CF, diabetes, metabolic diseases, IBD, the list goes on and on. Now, if you were to add up the prevalences of all those conditions combined and put them together and just carve out the complex kids, we think that the true prevalence of them across the United States is about 2 to 4 per thousand, less than 1%. So you're looking at maybe around 400,000 US children with medical complexity out there. But because these kids engage in the healthcare system so much, they account for about 1/3 of all pediatric healthcare costs. All right? That's around $650 billion annually, which is 2% of all healthcare spending of all individuals of all ages across the US. Now, the breakdown of this spending is pretty interesting to think about. All right? So of that $650 billion, about 1% of it goes to home care nursing, PCA, things like that. 2% goes to primary care. 3% ED, 13% pharmacy, 25% specialty care, and 47% goes to hospital care. So a lot of people look at this allocation, this distribution of spending, and think, maybe this is a bit misbalanced. Maybe if we have more spending on the primary care side, the outpatient side of things, we could derail some of the need for these children to be in the hospital so much, and their hospital spending would be less. In our children's hospitals across the United States, we definitely feel the presence of these kids, and I felt it here in residency, and I know you guys do too. These children with medical complexity account for about 55% of all of our inpatient revenue across all our children's hospitals. And when you look at particular types of admissions, like a 30-day readmission following an index admission, children with medical complexity account for 85% of all those healthcare costs. So the message here is small population size and ginormous impact on the healthcare system. But the story doesn't quite end there, because over the latter half of the last decade, children with medical complexity were the fastest growing population within our children's hospitals. Shown in the red line here, their population size increased by about 30% or so, which was twice the rate of rise of children without a chronic condition, shown in the blue line, and children with less complex chronic conditions, shown in the gray and the black lines here. I think it's important to kind of pause for a minute to talk about why we think this is happening. 4 things to think about. 1, there's just improved survival of some very fragile populations out there. I mean, you guys know this. Survival of our infants with severe congenital anomalies, extreme low birth weight infants, extreme prematurity, fantastic NICU care, fantastic surgical care. These kids are surviving, but they're surviving at a cost. They're going on to develop comorbid conditions, pulmonary, musculoskeletal, GI, et cetera. And when those things become exacerbated, that brings them back into the hospital. Secondly, I think as a culture, we're operating more on these children than we were in the past. Here's some national data that Raj helped me with, looking at rates of gastrostomy, numbers of gastrostomy and tracheostomies performed in children with complex neurologic conditions. kids with cerebral palsy, congenital brain malformations, muscular dystrophy, spina bifida, et cetera. 25 to 35% increases in these devices placed in children over the last decades. Hospitalizations are required to put in these devices, and we all know about the complications that these children experience after they're in that leads to more hospital use. Third, just the fact that these children are hospitalized when they transition home, it's tenuous for them, and so many of them fail that transition and have to come back into the hospital. Across our U.S. children's hospitals, we know that the 30-day readmission rate for children with medical complexity hovers between 20 to 30%, which is equivalent to the readmission rates experienced by complex Medicare elderly beneficiaries with multimorbidities. We know that we're not doing the best job that we could do, I think, preparing families to go home with all of our discharge planning. A couple of years ago, we surveyed all the families from our complex care service, asking them how prepared they were to go home, how they could manage their child's health, and we had some very disappointing findings. We found that about 15% of our families said that they did not feel their child was healthy enough to be discharged, even though we had discharged them. And families that answered that way on their survey, their children had an odds of readmission of over 3 within the next 30 days. Similar findings for families that said they didn't understand how to manage their child's health after going home. So it's a big deal preparing families to leave. Third, you guys know this. There's so many families that are running many ICUs in their homes, really, to keep their children going. And I don't feel like we really have the community support and systems in place to try to help them, especially from the home care side and the post-acute care side, which could really help these children and families. These facilities are certainly out there. You guys have South Davis here, which is absolutely wonderful. We need more places like that, I think, to help transition these kids home, which could also help them prevent from coming back to the hospital. And finally, there's this notion that some hospital use for children with medical complexity occurs because the children's outpatient care and the outpatient health system is just not supporting them as well as it could. So there are too many kids out there that have chronic conditions that are not controlled as well as they could be. Their medical technologies are just not being monitored closely enough so they malfunction. And these children are experiencing acute illnesses that are not being addressed promptly enough to mitigate the severity of them so they don't need to come into the hospital. 2 data points that resonate with me here. 40% of children with medical complexity do not have an annual primary care visit with their doctor. All right, they're bouncing around among all their specialists, which is great, but there's not a person there sort of pulling it all together. Relatedly, about 44% of these children have one or more major unmet health care needs at any given time. We're talking about medications being hung up in prior authorization, durable medical equipment that's been denied, more home nursing that they need that they can't get. This is big stuff. And because of this, there's so much of a burden, I think, that ends up falling on the family's shoulders to try to pick up the slack for all this. Some of our families are spending 20 plus hours a week trying to hold it together with direct caregiving and picking up all the care coordination tasks that the providers are not doing. Many families experience loss of employment, marital discord, physical and emotional health consequences because of this. It's really sad. A recent study by Mark Schuster quantified that there's probably around $18 billion in lost wages out there for parents who've discontinued work to stay home with their families. And if we had home nurses coming in and PCAs and other folks trying to help, that might be another $36 billion in jobs out there. So if the Trump administration is listening to this Grand Rounds presentation and you're considering building a wall, which might be great, maybe you could divert and think about this valuable influx of jobs that you might be able to offer. Just my 2 cents on politics. Okay, so let's move on now to talking about some different activities and approaches that are out there for really trying to manage care for these children the best way possible. So a few years ago in our clinic, we kind of sat down together and we said, what are we trying to do for these kids? We can't make them 100% healthy. What is our goal? We said, all right, we're trying the best we can optimize the health and quality of life of every kid in our clinic. We're trying to minimize the severity of acute illnesses that they encounter. We want to minimize the number of times they experience chronic condition exacerbations, any type of pain and suffering, and the burden that the families are experiencing caregiving for them at home. At the same time, we want to maximize their functional status, their cognition and development, their time away from their hospital, and their time at home and in school. I said, all right, it's great to articulate that, but how do you actually do that? We came up with 5 things that we think all children with medical complexity deserve. Number 1, they deserve to have care that's managed by at least one provider who's knowledgeable of the child's overall health and well-being. So this is Nancy Murphy, right? This is the one person who's going to sit there and be on top of every single comorbid condition, every med, every piece of durable medical equipment. They're going to know the ins and outs of the clinical nuances and the family nuances. and be able to manage the entire healthcare team, right? Number two, the care has got to be coordinated among the child's team members when making decisions. For our clinical case of our kid with cerebral palsy, if the orthopedic surgeons stand up and say, your Cobb angle with your scoliosis has reached a certain threshold, I think it's time to fuse your spine. In an ideal world, they're going to at least elevate that potential surgery out to everybody to weigh in. Maybe pulmonary comes back and says, ooh, this kid's got horrible central apnea. We've been trying to put him on BiPAP for years. We got to get that sorted out. The neurologist says we've got to get seizures under control. And maybe Dr. Murphy stands up and says, well, what's the actual quality of life benefit that's going to occur from the surgery? Let's all sit down and talk about it. Third, the care's got to be relentless in meeting the child's healthcare needs in a timely manner. This is not about writing a script for a MOX for an otitis and walking away. This is, how do we get 10 more hours of home nursing in the home for this kid? That's going to take 20 phone calls to the state, 8 letters of medical necessity, maybe calling some politicians here and there to do a favor. Like, you're really trying to do your best to try to get these kids what they need. Number 4, the care's got to be proactive in making plans to optimize the child's health and quality of life. Thinking to the future of what's going to make these children get sick and trying to completely do away with that or mitigate the severity of it. For our kid with cerebral palsy, maybe we say this kid's going to have 2 aspiration pneumonias this winter. He's going to have a UTI or 2. When those happen, the seizure threshold's going to lower. Let's put in plans in place to try to address all that ahead of time so that maybe we can help. And finally, the care's got to be accessible, especially for health problems that require urgent attention. So even if you make all these plans, I firmly believe you've got to have an outpatient clinic, not the emergency department, that's going to be there for these children to help them when they need it. That can be really hard. 4 or 5 hours sitting in a primary care clinic getting labs and tests and hanging out and doing nabs and all this stuff, but I feel it's very important that the kids have that. All right, so let's get back to our healthcare team of our case here of our child with cerebral palsy, and let's go through a few different examples of what happens when different people on this team step up to take charge and to do those care attributes that I just described. So it's absolutely amazing when primary care physicians stand up and do this, right? And there are some phenomenal examples of that happening in the literature. Judy Palfrey's work from Boston, Pat Casey from Little Rock, Arkansas, and Ruth Stein, the matriarch of children with special healthcare needs from the Bronx. I'll speak briefly about the Judy Palfrey work in Boston because I know it's in my backyard. So her work is basically an example of how do you set up a medical home for children with medical complexity. It's pretty simple. She took about 13 primary care practices. She carved out the complex kids from all those practices. She gave every kid a assigned nurse practitioner and a parent navigator to help them. They gave these kids hour and a half long well child visits. They put together these individualized health plans. They expedited referrals and communication with all the specialists at the Children's Hospital, and they set it up. They kept the kids out of the hospital. They improved their health, and it worked. I mean, this is fantastic when a primary care practice is able to do that. The problem is there's so many practices that are just not equipped. They don't have the infrastructure. They don't have the funding in order to be able to do that. And so many primary care physicians, I think, and myself included, are relying so heavily on the specialists for guidance, for care plans, and decision-making and everything else to help. All right? There's some phenomenal examples out there of these hybrid medical homes where the specialists and the primary care physicians all get together and sort of work it out. One great example of this is the University of Texas Houston High-Risk Children's Clinic, run by a pediatric pulmonologist, Ricardo Mosquera, who embedded himself and some ID docs into the general peds clinic. Pulmonary and ID being in there is pretty interesting. They said there's so many pulmonary and ID issues with these kids, especially for their urgent care, that they felt that they could help. They created this awesome rapid response system where they would give the families their cell phone numbers as the first call for any urgent care problems. They had a rapid responder of the day. This is not a call going to nursing line checked on the hour. This is you get me now. They had dedicated people to rapidly respond every day, so they're not doing other tasks, and their full job was to take care of the problem, bring the kid into clinic, and take care of it. They'd see kids after hours, on the weekends. They had all these PDSA cycles for their contingency plans. Like, what are we doing for aspiration pneumonia? We tried Clinda, we did these nebs, we did the cough later, it didn't work, what should we do? Just absolutely amazing, and they've proven that they've done a great job improving the health of their kids. Fantastic stuff. Now, there are other models out there as well, and Nancy's here is like this, where you have this consultative medical home where you sort of overlay on top of everything this other clinical team. And you have this dedicated clinic where every child in that clinic is a child with medical complexity. So it's a structured clinical program dedicated for those children. One great example of this one is the Children's Hospital Wisconsin Special Needs Program, run by an ICU doc named John Gordon. So John was in the ICU for about 20 or 30 years and decided that he wanted to step out because he could do a better job helping the kids in the community. So he started an outpatient program. This guy's not afraid of anything. He would start ECMO and pressors at home if he could. You know what I mean? The parents love him because he is just not afraid to back down from any event that the children are experiencing. These guys are spending up to 20 hours per patient per month helping them. Just let that sink in. Like, think about your time. 20 hours per patient per month. They're ubiquitous. They go to specialty visits when the kids have them. They're in the ED, right? They go in the ICUs or in the hospital. They do home visits. They communicate with everybody. They try to be the moderator when there's discordance in plans between different people. They develop these wonderful plans of care. Wisconsin Medicaid loves these guys because they feel like they really are bending the cost curve there. The hospital, however, has a bit of a different view for them because of their 200, 300 kids in the program, and with all their structuring staff, they run on about a $400,000 or $500,000 annual deficit because most of the things that they're doing to care for these kids are not reimbursable. Keep that data point in your head. We're going to come back to that a little bit later. So our program that I'm affiliated with at Boston Children's is sort of a combination of a primary medical home, a hybrid one embedded with a specialist, and a consultative one. It's sort of been growing now for about 30 years, and I just sort of stepped into it, which has been really fun. We've also stood up an inpatient side of things. We have our own dedicated hospitalist service. We have a presence in the ICUs as well. We've got a home visit program and are also integrating heavily with their anesthesiologist in surgery and perioperative care. We also link in with all the other clinical programs ongoing in the hospital with children with medical complexity, or LTV, short gut, palliative care, backflow pump, and our epilepsy programs. And it's been really fun to work in this clinic. At the moment, we have about 41 personnel now serving around 4,000 children throughout New England. We're heavy on the nursing side, surgery side, general peds, hospitalist, and specialty side of things. You know, I put this up not to boast or to say, you know, how great this is, but to say, like, over these decades, like every 6 months or so, there's a new clinician in the hospital that says, I really want to take these kids on. Like, what can I do? And we just like sink our hook into those guys and reel them in, you know, and include them in our protoplasm of care. And that model has sort of worked for us over time to just keep building and building and building. Our catchment area is pretty big, not as big as what you guys have here. And that's an issue, right? Because these kids are coming from everywhere to utilize these tertiary care children's hospitals for complex care, but you're not there for most of the kids to really help them locally. You know, you can be on the phone with them and all that stuff to help, but it's just not the same, I think, as having providers who are uber local to really be empowered to take care of them. So that's where I think the most innovative opportunities are for trying to care for these kids, is really how can you engage these community providers to step up. Community case management in particular. There are some awesome examples out there of some really neat things going on in that area. From my home state in Alabama, also in Victoria in Australia, and in the Ontario province in Canada as well. I'll speak briefly about the Alabama program. There's so many things about my state that just drive me crazy, but I love this thing right here. So the state of Alabama divided itself and its Medicaid program up into 5 regions. And it hired nurse case managers within those regions to go find the complex kids living in rural areas. They found them, and then these case managers embedded themselves into the rural primary care practices throughout the state. The primary care docs loved these nurse managers, case managers, so much that they onboarded them into their practice. They gave them physical space to sit. They also gave them the ability to see patients and to get into their electronic health record. So now these nurse case managers can see the electronic health record side of things from the primary care side. They also have access to the Medicaid data, right? Because they're employed by Medicaid, so they can tell when patients refill their medications, who's overdue. They can tell when things are hung up in the bureaucracy for durable medical equipment renewals and things like that. Absolutely phenomenal. They do home visits. They integrate well with the Children's Hospital of Alabama specialist, and have performed layered on a very nicely elegant system to try to help kids in rural areas, which I think is really wonderful. You know, at the end of the day, it really doesn't matter if it's a primary care doc or a specialist or a combination thereof, or a community case manager or someone who's trying to help these kids. Ultimately, you just want somebody on the healthcare team for every child to stand up and manage the care, to coordinate it, to try to be as relentless as possible in meeting the healthcare needs for the children, to proactively think about what's going to happen to them in the future and to try to help them and to make the care accessible, especially for urgent care problems that can occur. All right, you guys still with me? You good? All right, so let's move on now and think about all those care management activities and talk about their effectiveness and their impact and the relationship of them with resource utilization and cost. So there's a growing body of literature that's trying to quantify the impact of all that care management in children. And there's no question that the vast majority of it is pointing in the same direction, showing that it does have an impact on the health and well-being for the children. It reduces their unmet health care needs. It improves their health and their functional status quantified. It also has a great benefit for the families. It increases their knowledge of their child's health, especially around prognosis. It helps with coping. It literally reduces the number of hours that families are spending at home caregiving for their children, and it improves family satisfaction with care. So when you see this stuff, you're like, yeah, all right, this is working. Moreover, this high-quality care management does have an impact on health resource use as well. I mean, if you're really engaging in these children and trying to meet their healthcare needs, you're going to bring them back to your outpatient clinics probably more frequently than they were before you enrolled. Some of these studies report a 70% increase in outpatient visits for children with medical complexity after they enroll in an outpatient complex care program. Relatedly, though, if you're really improving the children's health and you're mitigating the severity of acute illnesses that they have and you're preventing them from getting in the hospital, then you really are making an impact in their hospital and ED use. These studies show that hospital use can be avoided with admissions reduced by up to 59%, days in the hospital were reduced by up to 50%, ED visits reduced by up to 55% for children exposed to this care management. Now, I told you before that hospital use and ED really equal up to about 50% of the total spend for these children. So this is where all this cost savings is supposedly going to occur by reducing all these things, right? Now, if you're a parent or a complex care provider or an insurer and you see these numbers, you're like, heck yeah, like this is great. This is absolutely fantastic. But on the flip side, if you're the chair of a department of pediatrics or the CEO or the CMO or the CFO or the CNO or the COO or whatever of a children's hospital, you may look at this and say, holy shnikes. All right, so wait a minute. We're going to invest in these outpatient complex care programs that are going to lose $500,000 a year for every 250 kids, and you're going to keep the kids out of the hospital. You just told me that 55% of our inpatient revenue is due to these kids, and we're going to cut that in half? So a quarter of our beds are going to be open? Like, we're out of business. This is awful. Well, before you get too despondent or elated about all these numbers, you need to contextualize them in the methods that were used in the studies to generate all these findings. So of these studies, we've had a couple randomized trials, which have been rigorously designed and are fantastic. But the vast majority of the literature out there are these pre and post interrupted time series retrospective studies that don't have a control group. They're measuring hospital use for these children in some prior baseline year. They expose them to the care management system. They measure the hospitalizations again, and they say, oh, we had a big decrease across the board, without really seeing what would happen with the control group around that. There are issues with that. Here's one of them. A lot of the selection criteria for these studies and these care management programs include that the children enrolled have to have multiple hospitalizations in this prior year in order to be eligible for the program. So a kid may need to have 4 hospitalizations in the last 6 months, and they're flagged to be enrolled in one of these complex care management programs. That's an issue because the vast majority of children that have hospitalizations that frequently don't keep going to the same level of having that same degree of hospital use. They regress down a bit. That high hospital use is transient. So case in point here, we did a study a few years ago where we carved out across all the children's hospitals, children with medical complexity, and their hospitalizations in the year 2009. These children had a median of 2 hospitalizations during that year, all right, shown in the left panel, and those hospitalizations combined cost about $150,000 median-wise on the panel on the right. So then we went back and looked at retrospective 2 years from that to count their hospitalizations, and then counted forward 2 years, and look what happened. Most of those children were not hospitalized in the year prior or the year after, and the vast majority of these kids were not exposed to a care management program. So if you don't have this naturalistic sort of flex in what's happening with their hospitalizations, and then you throw in a care management program into the middle of this without really thinking about it, it may seem like you've really done a fantastic job of decreasing hospitalizations. You still may have done that, and I do believe that you did, but maybe it's not to the same extent that the data may show. More on this, for those of you especially who are interested in this kind of thing. The Congressional Budget Office, the CBO, released a report in 2012 where they reviewed 34 care management programs for complex elderly Medicare beneficiaries, where there's a lot of evidence on how to manage their chronic diseases. Only 2 of those 34 programs that they thought were actually successful. Those 2 programs had a 10 to 20% reduction in hospital use, not the 40 to 60% reported in the pediatric literature. And in only 2 of those programs did the cost savings from that hospital reduction exceed the cost that it took to stand up the clinical care in the case management program. Those 2 programs are very, very similar to the John Gordon program in Milwaukee that I described, and also Nancy's program here. So my 2 cents on all this cost stuff is that I think we need to stay focused on what outcomes are really the most important here. Cost is important, but I think it's secondary, right? Keeping the children as healthy as possible and helping their families as much as we can should be the priority. And I honestly think we should be very realistic and upfront about spending money to achieve those outcomes. I don't know what the Medicaid reimbursement rates are like here in Utah, but in Massachusetts, we're probably reimbursed about 60 cents on the dollar of our cost. And around our surrounding New England states, that can be even less. New Hampshire may be about 15, 20 cents on the dollar. And if Medicaid's not even reimbursing us for most of the care management activities that we're doing anyway, all our telephone calls, multidisciplinary team meetings, et cetera, then aren't they underspending already? Why do we have to talk about cost savings to get some infusion to move the health system? They should just spend what they need to spend for it, and let's get the job done. All right, so let's wrap things up now by talking about some healthcare policies that are out there to try to enable a better healthcare system for these children. So healthcare policy is important for children with medical complexity. This is mostly for the learners in the room. You know, I had no idea really what healthcare policy was as a resident. Insurance-wise, I knew that it sort of helped us get paid, but other than that, I really didn't understand what it was. This is very important for children with medical complexity. You know, private insurers tend to limit access and services for the children, right? They have sort of their in-network providers. If children are coming from out of state, maybe providers here at primary are included in those in-network providers, and that can be problematic. We definitely see this in New England. A lot of the times the private insurers just flat out don't pay for things like home care or durable medical equipment. And so the families have to go to public programs like Medicaid in order to get that, right? Obviously, there are families living in poverty and children that have severe disabilities that enroll directly in Medicaid to get their needs met. So there's so many children relying on public programs in order to get access to care for children with medical complexity. And when you're relying on Medicaid, then you're secondarily relying on your state legislatures and their funding and how well they're put together in order to fund these programs, which really affects the quality of them. I'll say this again. The cost of care management that we're currently doing for these kids exceeds so much the payment that's received by clinicians from Medicaid that we're all forced in the healthcare system now to figure out how to underwrite all this financial loss. We're subsidizing these clinics and care management programs from other hospital departments, from philanthropy, from research grants. I mean, how unstable is that? I just find that to be absolutely ridiculous. The health system should be built around these kids, not band-aided by this stuff. So to me, it's the healthcare. My question is, how can healthcare policy mitigate this? I don't want to see this anymore. I want to see a stable system. Luckily, there are programs out there that are trying to make that work, even in the current fee-for-service environment. So here's one example. Michigan Medicaid put in a policy where they are paying $100 a month per child with medical complexity for care coordination activities. All right, now $100 a month may not seem like a lot of money. That's $1,200 a year per patient. But if you've got a nurse with salary and fringe that's costing about $100K, and that nurse is billing for, under this mechanism, of 80 patients a month, that will cover his or her salary. Same with the social worker that's billing for about 60 patients a month. All right? So this policy is enabling, an expansion of healthcare professionals in the system to care manage for these children, which is absolutely phenomenal. They're using these CPT codes, which we use all the time for other areas in primary care and outpatient care, but home visits, team conferences, telephone calls, care plan oversight, like all the good care coordination stuff that you want to do, which is really wonderful. Other states out there are moving to this Medicaid privatization model. I don't know if you guys are experiencing some of this here. where the state governments are outsourcing their administration and care to private managed care companies or health plans to take over the Medicaid managed care. This is leading to a lot of variation in the approach for doing this. There are some states that are taking this on and they're in an enabling way, like they're actually infusing case managers to do home visits for children with medical complexity as part of their program, which I discussed earlier through Alabama. But there are other state Medicaid programs that when they enroll in this managed care stuff, that they're using this slashing and cutting services MO in order to decrease cost. There's some horror stories out there, and a lot of it's being written up very nicely in the press by Elizabeth Cohen and her team from CNN, of stories where children are, at home and they're receiving a letter in the mail that's saying that their home ventilator is no longer covered under Medicaid, and the family has to fight to get it back. Or starting next Monday, your home nursing hours have been cut from 40 to 10, and you have to, do whatever you can to go advocate to try to get that back. I don't think that's great. So what you have when you start dealing with states is variation in the way that these states are approaching things. And you have variation in health system performance across states. This is national data from the Children's National Survey for Children with Special Health Care Needs Survey, parents' perception of the health system performance for children with special health care needs, darker states perceived by the families as having a higher performance state, lighter shading in the white states for those that may be on the lower end. The point here is that I really think that children should have access to high quality care in a health system regardless of what state they live in, and that should be the norm, and we should really try to get there. In order to do that, then, you're talking about federal policies that are going to overlay across these states to make them do their job, which is very tricky. There is currently a bill that is sitting in Congress that is specifically for children with medical complexity. I think this is by far the coolest thing ever. So this is Bill H.R. 4930, and it is specifically for care management for children with medical complexity. It's called the Advancing Care for Exceptional Kids Act. I don't know if you guys have ever tried to read legislation. It is like the most epilepsy-inducing language you could ever read. I mean, if someone would put an EEG on me reading this stuff, I probably have like 20 absent seizures a minute just trying to go through this stuff. But from my take on it, the purpose of this legislation is to create these geographic health homes that include every single member of a child's healthcare team. So that kid with cerebral palsy that I put, everybody in that healthcare team would be involved in a health home regardless of the geographic location. So even if that spans across states, everybody's linked together, everybody's accountable for the quality of care that's delivered to these children, and they're also on the hook a bit for the cost of care as well. All right? Through this mechanism, the feds would be able to give, per child enrolled in this program, money directly for the states to infuse into every child's particular health home to spend where they see fit to help the children. All right? So in theory, this could be really awesome. This thing is gaining bipartisan support. It's got about a third of the House and a fourth of the Senate who are co-sponsoring it. It's been scored by the Congressional Budget Office. It's made its way through the Energy and Commerce Committee review this summer. There are legislative text revisions now ongoing in both the Senate and the House, and a lot of momentum building. And then we had a transition to our new leaders. And now everything is sort of on hold because no one's really sure what's going to happen. Are these guys really going to kind of carry things through with their take on government having less involvement in state Medicaid programs and funding? And if that's the case, they may not be up for more federal regulations put on states for care management for children with medical complexity. So what will they do for these children remains to be seen. All right, that was a lot. Some of you are still smiling, which is good. So I hope this was helpful. We covered a lot of ground. We talked about the prevalence and impact of these children on the healthcare system, different activities and approaches to managing their care, relationship between quality of care and cost containment, and all these enabling healthcare policies that are going to hopefully benefit the children. Most of all, I hope that you maintain your motivation for trying to do what you can to help these children. Again, I'm going to try not to get emotional here, but you guys motivated me to do this, and I can't thank you enough for that. These children deserve every bit, every person in every state and every children's hospital to do what they can to help them. So that, my friends, is the State of the Union for Children with Medical Complexity, the 16th day of March, 2017. Thank you very much again for having me. I'm happy to fill any questions that you may have.
Hello.
Dr. Fakes.
Thank you. As healthcare finances gradually make the transition from fee-for-service to capitation, whether or not it's adequately funded, will you opine as to what impact it may have on the possibility of aligning the interests of the hospitals and the patients and complex care providers?
It's a great question. So we're in the middle of a project now. We're taking about 12 states worth of Medicaid data, and we're applying all the rules from the Medicare Shared Savings ACO program into that to try to figure out what would have happened had these kids been enrolled in the ACO and they've had their capitation rates and everything sort of put on top of it. And what we're finding is a lot of these kids end up exiting out because they have such catastrophic health expenses that they sort of go on the other side of the risk corridor a lot of the times. And so for a lot of the kids, they won't even really be enrolled in the programs going forward. Now for the kids that are staying in, we're trying to figure out what's happening with them as well, and what's happening with their allocation of spending and how to link everybody together. I think it remains to be seen. We have a small local project ongoing now with one of our Medicaid managed care companies to have a little ACO experiment with full risk ongoing now, which will launch off in October. And everybody's so nervous about it because they have no idea what's going to happen. So more to come.
Thank you. You've done great work. It seems like sooner or later, return on investment has to make sense to somebody. So I'm wondering, given all the vagaries in that, the difficulty of measuring return on investment, comparing with and without the programs, and particularly the underpayment currently for a lot of the programs or a lot of the kids that are involved in this. Do you see a way to really measure that? And do you think that there would be a return on investment when all the other things are considered, particularly parental work hours, et cetera?
I think all the outcomes that are out there that are measured they're good enough to me. I really do. I mean, all the quantifiable scales that talk about quality of life and functional status and all that stuff I think is great. Satisfaction with care is great. Caregiving burden. And this utilization stuff has merit. I think when you put all that together, I think you can sort of get an ROI sense of what's happening. I will tell you this, though. Other countries are moving beyond trying to quantify this. You look at the government at Victoria in Australia, and their complex care programs are a hard line item in their budget. And they say, we don't want you spending time trying to figure out how to measure this. We don't want your care coordinators to be spending an hour a week inputting data into a database and then show us a trend in this or that. We want you to be delivering clinical care. We get it. This is important, and we don't need anything else. So go forward and do your work. I would hope that someday we might be able to make it on the same level as they do.
Thank you. That was really a beautifully presented picture of what we're at right now. As a system, we are faced with budget constraints and paying for these kids within our system. As a state and as a nation, we have an obligation, though. So how do we balance that out? Where do we draw the line on rationing care, on medical futility? You knew I was going to say this. On the ethical decisions that we make? If we're putting 30% of our healthcare dollars into 1% of the population, what's happening to the other 99% of the kids?
Oh my gosh, Dan.
A bit of a rhetorical question, but I think an important thing for all of us to think about is where's the balance?
No, you're totally right. You're totally right. And I'll have to say that I think that a lot of the population of kids is, the non-complex kids are sort of taking second fiddle a bit, which I don't know if that's right. And, thinking about kids with less complex chronic conditions that are more prevalent and engage the health system a lot. And there's certainly some waste in the system for those kids as well. Excessive things that you could clean up on the population level that might even be easier to clean up in a way. And the money saved for that might even go and help the complex kids. You know, there's so many different ways to think about this. So much of what we do for these kids is palliative. I mean, let's just put it out there. In fact, maybe almost everything we do for them is palliative. And a lot of those things are very expensive. And we know that on paper, on an x-ray, a straight spine may look beautiful. But if it really isn't having a major impact on the quality of life for the children, and sometimes the kids come out even worse sort of health-wise afterwards, I think we've got to do a better job of figuring out which kids really benefit from those major things and which ones don't. And to be continued. And I would love to continue this conversation with you over a beverage or two today if you have time.
Anyway, so you described a few different approaches to complex care, and one of my abiding interests has been the relationship of complex care to primary care. And given that this is a very small proportion of the population, so no general pediatrician is going to have enough experience to do the kind of or have that kind of expertise needed to really master this or to really lead the care. Plus, the impact on their practice it would be significant if they were to try to do that. Yet, I see that the kids who are just not quite this complex, I mean, if this is 1 or 2%, even being generous, okay, what about the next 5 or 10 or 15%, which is sort of where Nancy was going, I think. Yeah. How do we optimize care for that population, partly to prevent them from becoming part of the 1%, but also perhaps have a even better return on investment, if you don't mind that analogy?
Yeah. There's some interesting work out of Raj's neck of the woods in Ontario where Sick Kids has sort of led this nice education program where their complex docs go out and have one-on-one didactic teaching sessions with the community pediatricians, even their local hospitals. And not just in general about topics, but like, okay, you're caring for the 10 kids in your clinic, in rural Ontario that are coming to Sick Kids. Let's sit down together and review these 10. What questions do you have? What clinical proficiencies do you wish you had to be able to triage things? What makes you scared about when these kids show up with fever and everything else? Like, let's talk through this together and learn together, and let's enable you on a case-by-case basis to learn these kids. And they've found it to be pretty effective. I almost think if you could do something like that, even with that second tier of kids, to really figure out with population health data, like what conditions are we talking about? I mean, do we have asthma down? Okay, we have asthma down. It's not asthma. But maybe it's these 4 or 5 conditions, and mental health's got to be in there, and we really figure out a way to teach, post-residency, out there with these guys in order to get them up to speed on what to do and to feel comfortable managing this stuff. Just a thought.
That was a great presentation. I wondered if you could say something about care in the home and what role that might play going forward. It seems like there was a time in American medicine where care in the home was a big part of everything, and now it's basically the realm of hospice and home care, which are both much less of an MD or NP run enterprise. So I saw one of the programs had a home care component, but not much else. So what role do you see that playing?
I would hope this really starts to make a comeback, home care, especially with these bundled payment and ACO type things going on. We've started a big movement in our program to get into the homes. So for example, our inpatient nurses on our dedicated hospice service for years have been screaming, we want to do post-discharge visits for the kids that we take care of, our staff nurses, in the home after discharge. So we set it up last year. We've done about 100 visits. There's been a median of 3 major issues that the nurses have found every single time they go into the children's homes. the SAP monitor is over in the corner that the cat chewed through the extension cord and it doesn't work. The med pill box is just out of control and it's not very organized. I mean, there's just all kinds of stuff that they're finding and absolutely loving it. Our LTV program, long-term ventilation program, is in the home, and we're trying to do more. We do a lot of co-visits with our palliative care team and the patient's home. So I really see this coming back. It's such a great place to have great discussions with families. You learn so much by doing it. Obviously, it was the mainstay of medicine, like you said, years ago. And I think it's going to be on the radar of a lot of ACO type experience out there to try to help these kids.
There's just an article that came out in one of the health information journals about exactly what you talked about, how far behind our country is with care coordination compared to other countries where they have a more universal payer-based system. I think some of that is probably due to the metrics problem that we have and what really works and what really doesn't, because we are bean counters here, for better or worse. My question, though, is do you feel, given the evidence that we have, it's even ethical to do a controlled study where you say, okay, these kids aren't going to get care management and these kids are, and we're going to see what happens? Because that's always my quandary is if I'm setting up programs, I don't want to say, okay, these kids can't have it because we want to measure. So as I see it, I don't know that we'll ever get there in case-controlled studies because the evidence tends to point to the fact that it would be unethical to leave them out, but yet without that, I don't know that those metrics will ever be solidified.
No, it's an absolutely great question. You're sort of caught in the middle of all this where you have to prove it on one side. You need the rigor to do it, but we know enough to where it might be helpful, so you really can't randomize. Like that, it's ridiculous. I think that the few randomized trials out there have done, got it through their ethics board by doing things like, look, the kids are in their usual care without this enhanced care management. That really is probably usual care for most kids out there. Maybe there'd be a lag. So we'll randomize to having your usual care for 3 months, but then we'll kick you in later on type of thing. Maybe there's some step wedge design kind of stuff where everybody's a control group for a little while and then they activate. So I think there's some nifty designs out there that you can sort of get around this ethics issue. But I totally hear you. I mean, how heartbreaking to be involved in one of these trials and they're unblinded. Who's getting the services and who's not, and then sitting there and watching a kid flounder when you really think that they could benefit from it. That's really, really difficult. Great question.
Well, I think this will be the last question. Dr. Young.
Great, Jay. But I wonder, do we know what the best kind of care management is? So why not compare case management style A versus case management style B?
So we don't know.
Yeah.
We don't know. We don't know. Yeah.
It seems like there's room for rigorous trials given the uncertainty of what the best, cheapest, most effective style of case management is.
That is totally correct. So a comparative effectiveness study of one approach versus another, and even on top of that, of which kid deserves which approach. Like it's not going to be one size fits all for everybody, and trying to figure out how to match kids to the best approach would be amazing. So lots of work to be done. Great point.
Wonderful. Thank you very much, Jay, for being here.
Thanks, guys.